Bismillahirrahmanirrahim. We are going to discuss a very important topic in our curriculum, which is puberty and its disorders. Just to understand how the pathophysiology of these pubertal changes occur. There is hypothalamic pulse generator that was discovered by the scientist Ernest Nobel. Hypothalamic pulse generator is responsible for controlling and production of the gonadotropin-releasing hormone from the hypothalamus, controlling both the mode of production and the amount. And there is hypothalamic gonadostate, which is a control of central feedback sensitivity by the gonadal steroids. Control pulsatile secretion of hypothalamic pituitary ovarian axis. And by regulating this hypothalamic pulse generator through the hypothalamic gonadostate, which under the control of central and peripheral regulations, these classify what will happen during the fetal life, during infancy, childhood, adolescence, till reaching to adulthood. During ensured fetal life and infancy, at 10 weeks, the GnRH secreted from the hypothalamus of the embryo, the hypothalamus 10 weeks of the fetus, secreting gonadotropin-releasing hormone. Then, at 9 to 10 weeks, the hypothalamic pituitary venous axis developed and completed by the age of 20 weeks. 20 weeks means equals 5 months pregnancy. Then, follicular stimulating hormone, luteinizing hormone, starts secretion at 12 weeks and peak at 20 weeks. So, at 20 weeks, there is full development of the hypothalamic pituitary ovarian axis, and there is start production of FSH and LH in considerable amount, reaching to peak at 20 weeks. After that, feedback sensitivity starts with negative feedback created by estrogen and progesterone from where? Not from the fetal gonads, from the fetal placenta. Then, after birth, with labor of the neonate and expulsion of the placenta, withdrawal of the placental hormones, estrogen and progesterone are lost. And so, gonadotropin remain fluctuating for a period of about 12 months. Then, hypothalamic pulse generator undergo inhibition and calm pass into a dormant stage till reaching puberty. This juvenile pause interval between infancy and puberty, during which gonadotropin-releasing hormone production with active hypothalamic pulse generator produce a small amount of gonadotropin, and steroids are produced from the ovaries in response to these gonadotropins, but still they are not ready to stimulate the mode of production of gonadotropin-releasing hormone in a pulsatile fashion. So still the hypothalamic gonadostate is immature in spite of production of small amount of gonadotropins and in response a small amount of steroids from the ovaries. This was changed to theory of diphasic pattern of gonadotropin and the fact that gonadal steroids affect mainly amount and not pattern of gonadotropin-releasing hormone production. Please don't forget that gonadotropins, which is a peripheral regulation of gonadotropin-releasing hormone production, are responsible for the amount and not the pattern. They are not controlling the pattern, only they are controlling the amount. Then, gradually estrogen and inhibin B increase secretion with maturity of the negative feedback first. Gradually, more maturation occurs. First, the negative feedback of estrogen becomes mature, and so the patient can develop menstruation, but still there is no ovulation. For ovulation to occur, there should be maturity of the positive feedback, which is the most important item before the occurrence of ovulation is maturation of the positive feedback mechanism between estrogen and gonadotropins. About 1 year after menarche, with production of mature level of inhibin A, with corpus luteum function being the primary source. So this hypothalamic gonadostate, higher center is under control, as we mentioned, by central neurotransmitters and peripheral signaling. The central neurotransmitters are very important because they regulate both the amount of production and the mode of production of gonadotrophin releasing hormone, while the peripheral signaling controlling only the amount. These neurotransmitters are classified into either stimulatory or inhibitory. The stimulatory includes the glutamate excitatory and kisspeptin excitatory. Both are responsible for increase the pulse frequency of gonadotrophin releasing hormone, while the gamma aminobutyric acid and neuropeptide Y are both inhibitory neurotransmitters. What about the peripheral signaling? The peripheral signaling includes leptin, play an important role in starting up pubertal changes, ghrelin as well, body mass index, body fat, fasting and malnutrition, neurological or neuroendocrine control of reproduction play a role as well. Now, after this introduction, I think it will be easy to understand what's puberty, what are the pubertal changes, how can we assess and examine, and then what are the common abnormalities we face in these women. Puberty means normal physiologic transition from childhood to sexual and reproductive maturity. Sexual and reproductive maturity. Pathophysiology of puberty, gradual development of normal production of gonadotrophin releasing hormone, that leptin play an important role. What are the pathophysiology of these pubertal changes? Please keep in mind there are 5 important pubertal changes occurring with puberty, and the underlying pathophysiology is important and actually easy to understand. First, we have adrenarche, puparche, and axillarche, which is one item controlled by the adrenal androgen, has nothing to do to some extent to gonadotrophin releasing hormone. And the second item is gonadarche. Gonadarche with activation of hypothalamic pituitary ovarian axis, development of pubertal growth spurt, stimulate both menarche and telarche. So we have 2 important pathophysiological events, adrenarche with consequently puparche and axillarche, then gonadarche that includes pubertal growth spurt, menarche and telarche. What is adrenarche? Adrenarche occurs secondary to increased adrenal androgen. So what is the source of hormone responsible for regulating this step of puberty is adrenal androgen, production of adrenal androgen that occur in response to adrenocorticotrophic hormone from the anterior pituitary that is regulated by corticotrophin releasing hormone from the hypothalamus. And it was found that for these adrenal androgens to be produced properly, there should be decrease in 17-hydroxyprogesterone. Should be decreased, should not increase. Okay, and so if there is enzymatic abnormalities in the steroidogenesis at the adrenal level, abnormalities could occur in these pubertal changes. Primary stimulus of adrenarche is unknown. Why the adrenal glands start to produce androgen? Why the hypothalamus and pituitary start to produce ACTH for starting this step of puberty to occur? Maybe leptin, maybe interleukin 6, compensatory hyperinsulinemia secondary to increased body fat, growth hormone, or insulin growth factor 1 may play a role. Now, adrenarche puparche result in development of pilosebaceous unit, and usually this stage precedes the gonadarche, growth spurt, menarche, and telarche by 2 to 3 years. The second item, which is growth spurt. Peak height is generally reached about 6 months before menarche. Bone mass is a critical item during puberty for development of peak bone mass. Other factors could be genetics, hormones, total body calcium. Changes in body composition, fat, and lean body mass occur with this stage of pubertal change, growth spurt. This phase is controlled by growth hormone. So the previous phase of adrenarche was controlled by adrenal androgens, but this phase of growth spurt is regulated by growth hormone. Gene of growth hormone located on chromosome 17, and placenta produces a variant amount of growth hormone. Gonadal steroids also play a role in increased production of growth hormone. Again, growth hormone exerts its action through insulin growth factor 1. So insulin growth factor 1 actually is important in the pathophysiology of different. What are the factors regulating the time of puberty? Genetics play a role, overall health, social environment, environmental exposure, racial and ethnic variation, nutritional status, and body mass index, body mass of fat distribution. What are the changes occur in the girl in association with puberty? There are tunnel stages of pubertal growth. Marshall tunnel staging. Marshall tunnel staging applied on development of breast and development of axillary hair. There are pubertal cascade of changes, start by growth spurt, followed by breast development, pubic hair, menarche, and finally axillary hair. Okay, so the pubertal cascade that's usually observed by the parents, by the environment, by the community is the start of growth spurt, then breast development, pubic, menarche, and finally development of axillary hair. These tunnel helped us to classify physical changes of puberty into 5 stages based on degree of breast development and pubic hair. For development of the breast, there are 5 stages. Pre-pubertal, actually, this is not signed here. Pubertal is just small and there is nothing above the level, the surface of chest. But the breast budding, this is the start of breast budding in which there is increase in the size of the breast. Breast budding start to be elevated above the level of chest with widening of the areola. Breast budding, stage of breast budding, which is stage 2 tunnel staging. Then breast enlargement and elevation above the areola. Breast enlargement and elevation above the areola. Then stage 4, further breast enlargement. Areola nipple forms secondary mold. The areola nipple forms secondary mold, as you see, and then reach to the adult full development of the breast with the beer-shaped normal breast contour. This is the tunnel staging classification of the pubic hair, pre-pubertal, then long, relatively straight hair, thin, present on the labia majora and known as pubis. Then sexual hair becomes thick, coarse, more distributed, but extend only to the labia majora, more thickness and density of distribution of hair, and then it starts to reach the inner aspect of the upper thigh. Hallmark of final maturation of hypothalamic ovarian axis is maturation of the estrogen positive feedback, which concerned with the start of ovulation. Without estrogen positive feedback on the LH to produce LH surge, there is no ovulation. What are the problems that could affect the different cascade, as we mentioned, for the occurrence of puberty? Anemia could play a role. Dysfunctional bleeding, sexually transmitted disease due to persistence of columnar epithelium at the level of ectocervix that predisposes to chlamydia and HB virus. So chlamydia and HPV virus infection very common during this stage due to persistence of columnar epithelium present in the ectocervix, which are vulnerable to infection by different multiple organisms, and so they are at risk for sexually transmitted disease, something that you should announce to the parents, that you should follow up for proper early identification and management. Premature pubertal event. There could be only one of these pubertal cascade of changes that could occur separately. How can we proceed for diagnosis? History is important. Exposure to trauma, headache, seizures, abdominal pain, exposure to sex steroids. Then after you take history from your patient, you plan for proper examination with attendance of one of your parents, clinical examination, and then you are going to send your patient for hormonal assay according to the data you got from history and clinical examination or radiological investigation. The most important one of the radiological investigation is measurement of the bone age, because this you will classify your patient, you will plan for her. Examination of my patient includes height, weight, body mass index, calculation of growth velocity, centimeter per year. Ocular examination is important for possibility of any underlying CNS disease. Skin examination for possibility of any metabolic or enzymatic deficiency as Macan Albright syndrome. Tunnel staging of pubic and axillary hair is very important for start of management and follow-up for diagnosis. Start of management and follow-up before treatment. Measurement of bone age is indicated when examination shows signs of sexual development. You should examine. This just revise the breast and pubic hair according to the Marshall tunnel staging system, as we mentioned before. What about the hormonal investigation? Based on history taking, based on examination of my patient, I'm going to do basal level of gonadotrophins, and if I am in doubt for presence of essential lesion to be CNS dependent or gonadotrophin releasing hormone dependent to precocious puberty, you should do GnRH stimulation test. Also, TSH and T4 if there is clinical evidence of hypothyroidism. And independent cases, when you find gonadotrophins are not elevated and in spite of this, the patient shows any signs of precocious puberty, search for other hormones that could be sourced for these changes. Estradiol for isosexual precocious puberty, testosterone for heterosexual precocious puberty, HCG, functional ovarian cyst, late afternoon cortisol Cushing syndrome, premature adrenarche hydroepiandrosterone, sulfate, 17-hydroxyprogesterone, and congenital adrenal hyperplasia. If you suspect that our patient has basal or gonadotrophin release hormone stimulation test positive, so shift for brain MRI for exclusion of any organic disease of the brain, abdominal and pelvic ultrasound for ovarian or adrenal tumors. This is a worksheet that could direct you how you are going to do and dealing with a patient with precocious breast and or pubic hair development. Ask for the bone age, if it is normal or advanced. If it is advanced, you should go for gonadotrophin releasing hormone stimulation tested for early diagnosis of cases. Either it is normal basal stimulated LH, so this is a case of gonadotrophin independent precocious puberty. You can search for other peripheral hormones as we mentioned, or you find them high for gonadotrophin dependent precocious puberty. Ask for MRI, exclude hypothyroidism, and in both cases you should do abdominal and pelvic ultrasound to exclude abnormal masses. If the bone age is normal, so breast examine for breast and pubic hair, breast and pubic hair and accelerated growth. To again this test, breast or pubic hair only, so it could be incomplete precocious puberty that needs close follow-up observation. How can we proceed for treatment of these cases of precocious puberty? Avoid the most important aim for managing a case of precocious puberty is to keep adequate height for this patient, to allow proper growth till reaching to the desired height, to avoid psychic trauma for such a patient, avoid premature epiphyseal closure and short stature. So we give gonadotrophin releasing hormone agonist to suppress any changes inside, and if there is tumor elsewhere, surgical removal of the tumor. Treatment of primary hypothyroidism if there, surgical or radiation of adrenal tumors, Macan Albright syndrome according to the condition, premature telarche or Adrenarche as we mentioned, just require close observation and follow-up. Hypogonadotrophic hypogonadism, trauma, infection, tumor, chronic disease, isolated gonadotrophin releasing hormone deficiency, Kalman syndrome. You know that the GnRH hormone is produced from an area of the hypothalamus called the arcuate nucleus. And this arcuate nucleus has the same embryological origin as the olfactory nerve. And so Kalman syndrome presented by hypogonadotrophic hypogonadism and loss of smell sensation. Hyperprolactinemia, malnutrition, excessive exercise, secondary hypothyroidism could be a cause as well. The last one is hypergonadotrophic hypogonadism, includes Turner syndrome or gonadal dysgenesis. For diagnosing of this delayed puberty, age is very important to identify if your patient has just delayed secondary sexual characters, or we are approaching to the magnitude of the problem, occupational exposure, stressful situation, malnutrition, habits, education, exposure to trauma, irradiation, chemicals, psychogenic disorder, neurological, endocrinological disorder, history of operation or pelvic infection or irradiation, family history of similar conditions also for constitutional delay, as we mentioned. Then examination, the same as we mentioned in precocious: height, psychic condition, weight, span, nutritional status of the patient, secondary sexual characters development, apply Tanner staging system for development of the breast and development of pubic hair. If there is any evidence of neurological disorder, especially central lesion, evidence of neurological disorder with a special reference to galactorrhea, hirsutism, and if there is any general condition of heart, chest, renal, hepatic, inflammatory bowel syndrome, hypothyroidism, presence of skin manifestation, skin patches, increasing carrying angle, any manifestation of abnormal syndrome as Turner syndrome, abdominal masses, external genitalia hypoplasia, and then we do pelvic examination for possibility of any. Then what about investigation? We do stage 1 or primary step just to classify them if it is hypogonadotrophic hypogonadism or hypergonadotrophic hypogonadism. This is important actually. If FSH, LH, and estradiol is high, so this is a hypergonadotrophic hypogonadism. You should do karyotyping. If they are low, so it is a central cause. You should do MRI, head, hormonal assay, and pelvic ultrasound examination. Step 2, search for specific cause, thyroid stimulating hormone, TSH assay, prolactin assay, dehydroepiandrosterone sulfate, differentiate from isolated deficiency and from constitutional delay, as we mentioned. MRI for hypogonadotrophic hypogonadism for central lesion, karyotyping, as we mentioned, for hypergonadotrophic hypogonadism. If hypergonadotrophic hypogonadism was normal karyotyping, 17 alpha hydroxylase deficiency could be there that produce sexual infantilism and hypertension. This is how can you proceed for delayed development of breast and or pubic hair development, your bone age, and gonadotropins, as we mentioned, to classify them. Hypergonadotrophic, go with karyotyping. Hypogonadotrophic, go for any central lesion or abnormal hormone production. Then treatment of delayed puberty, treatment of the cause, hormonal therapy for cases of hypogonadotrophic hypogonadism that in need for hormonal replacement or hormonal therapy, surgical treatment to correct anatomical defect if it is normogonadotrophic hypogonadism due to presence of Mullerian dysgenesis, endogonadal dysgenesis with presence of Y chromosome. If you find a case of hypergonadotrophic hypogonadism and you perform karyotyping and you discover the presence of Y chromosome, so these patients should be subjected to gonadectomy because of the great risk of malignant development in these abnormal gonads. And the earlier you remove the abnormal gonad, the safest for this girl to avoid her developing any type of abnormal malignancy. I hope the point is understood, and thank you.